Good evening and welcome to Doctors on Call. I'm Dr. Ray Christensen, faculty member from the Department of Family Medicine and Biobehavioral Health at the University of Minnesota Medical School Duluth campus and a family physician at the Gateway Family Health Clinic in Moose Lake. I'm your host for our program tonight on diabetes and other endocrine topics, including hyper and hypothyroidism. The success of this program is very dependent upon you, the viewer, so please call in your questions or send them in ahead of time to our email address, ask@pbsnorth.org. The telephone numbers can be found at the bottom of your screen. Our panelists this evening include Dr. Kanan Kasturi, a pediatric endocrinologist with Essentia Health, Dr. Krista Coite, a hospitalist with Asperis St. Luke's, and Dr. Jason Wall, a family physician with the Duluth Family Medicine Residency Program. Our medical students answering the phones tonight are Jessica Crossan from Hugo, Minnesota, Mackenzie Peterson from Laverne, Minnesota, and Wyatt Windhorst from Alexandria, Minnesota. And now on to tonight's program, diabetes and other endocrine topics, including hyper and hypothyroidism. Well, welcome, panel. There's a lot there. How we're going to cover it all, I don't know. Kanan, this is your first time with us. Do you want to tell us a little bit about yourself?
Sure. I am a pediatric endocrinologist, so I deal with children and their metabolic issues, metabolic and hormonal issues, on issues and diseases like type 1 diabetes, growth issues, puberty concerns, and hypo and hyperthyroid issues as well.
It's nice to have you here, so certainly don't be afraid to call in some pediatric questions. We have a family doc at the other end that can help out too. Generally, we go more for elderly, but
Sure.
It's nice to have you here, and diabetes takes us there. Mm-hmm. Dr. Coite, where are you practicing?
So I am at St. Luke's Aspirus, is the way I guess we're supposed to say that.
I knew I had it wrong.
That's all right. It's brand new. So I am there about 1 week to 2 weeks a month, and then I am actually the course thread instructor at the University of Minnesota Duluth School of Medicine for endocrinology and diabetes, and enjoy that.
Jason, welcome again.
Thanks, Ray. It's great to be here. I'm fortunate I get to work at the family medicine residency, so when people graduate medical school, they come to our program to be a family medicine physician. They're with us for 36 months, and they learn the whole gamut of, pediatrics, adult medicine, obstetrics, and everything in between. And I have the good fortune of working at St. Mary's and St. Luke's. So,
thank you for doing that. It's really great for the region and for the state. Krista, we talked a little bit earlier about the history of diabetes, and you said that you would tackle that for us.
This is one of my favorite stories. So if you like history and you like medicine, the story of the discovery of insulin is of utmost interest. So in the late 1800s, there were two German physicians who decided to take the pancreas out of a dog, and they discovered that that dog then developed the symptoms that were consistent with type 1 diabetes. The dog unfortunately perished, but that's how research was done back then. Then as time progressed and medicine progressed, there was a physician by the name of Frederick Banting, who was out of Hudson Bay in Canada, and he had a particular interest in studying what exactly the pancreas made to help treat type 1 diabetes. And so he actually hired a medical student to help him with his 6 dogs. Actually, he picked the medical student by the flip of a coin. His name was Charles Best, and the two of them were able to extrapolate what is now insulin from the pancreas of several dogs, and were able to keep a dog named Margaret alive for some time by using that substance. A young boy who was 14 named Leonard Thompson was the first human to receive insulin. It was sort of a sad story because at that time, uniformly, type 1 diabetes was lethal. So parents who could identify that their child was sick, and a physician at the time would diagnose the disease with the the bad message that, certainly their child would perish. So this discovery was revolutionary. It was life-changing. And Leonard Thompson's father was anxious to sign up for anything that would save his son, and so he was able to receive the first dose of insulin. Interestingly, Frederick Banting and Charles Best actually tested the insulin on themselves first.
Sure they did.
And so they were certain that it was safe, and then they were able to give that to a human. They went on to win the Nobel Prize, and actually it was awarded to a man named McLeod and Frederick Banting. I'm sorry, if this is too long, I could go on and on about this story. But
30 seconds.
Okay, all right. The fun part about it is that Frederick Banting decided that actually his student deserved recognition as well, and he split the prize with Charles Best, and the two of them decided, among the other people who discovered insulin, that insulin belonged to the world. It did not belong to them, so they did not take any royalties from the discovery. They sold the patent for about $1 to the University of Toronto, and mass production of insulin ensued. And so it's a wonderful story of selflessness, of discovery, and of medicine.
Thank you.
If I may add, he said specifically, I do not want people to profit out of this drug. I want it to be free. And of course, people have never profited out of insulin, right? They've never made big money from big pharma. Hasn't made any money on insulin. So it's true to their word.
So, back to you now as the pediatrician here.
Yes.
What's the difference between type 1 and type 2 diabetes?
Yeah, so type 1 diabetes is an autoimmune condition. The body's own self destroys this islet cells of the like pancreas that do produce insulin, and so there is a deficit of insulin. With type 2 diabetes, there is no deficit of insulin. There's enough production of insulin, but what happens is the insulin is not able to act properly, either because it's not able to sit on the receptor or it's not able to function. So in type 1 diabetes, there's no insulin. In type 2 diabetes, there's actually excess insulin, but it's not able to function effectively.
Jason, prediabetes, is that reversible? And just kind of describe what prediabetes is and how it relates to diabetes, maybe to start.
Certainly. There's a continuum. Let's say normal blood glucose is, let's say usually around less than 100. And diabetes would be consistently more than 126. These are all just arbitrary numbers that, modern medicine has arrived at. But there's a range of, let's say 100 to 125, where we would call that, elevation in blood sugar over time, prediabetes. And I think just because the sequelae, the downstream sequelae of diabetes are, increased risk of kidney disease, kidney failure, dialysis, heart disease, peripheral vascular disease, amputations. You're immunologically suppressed, so you're more at risk for infection. All those, the sooner we can identify and treat diabetes, the better off we're going to be. We're going to have healthier people, healthier communities. And so, while the path to frank diabetes is can be gradual, it's prediabetes is sort of that wake-up call.
Krissa, what do you? You're an internist, I believe. How do you treat diabetes? What's your sequence, and how do you go about that?
A great question. So, of course, we look at the whole patient, and we do what's called shared decision making. We assess how bad the situation is. We usually use a measurement called a hemoglobin A1C, which is a measure of how someone's average blood sugar has been over the past 3 months. If it's really, really high, then we may have to jump to some more aggressive measures. But if it's not too bad, like if it's just the marker for actually the diagnosis of diabetes would be a hemoglobin A1C of 6.5 or greater. And so if it's close to that 6.5 mark, we might say, well, let's have our little wake-up call like Dr. Wall was suggesting, and let's institute healthier eating, more exercise, better sleep. maybe we might take a look at whatever is going on in that patient's life, and then we'll assess, for example, whether there is a need to introduce some medications. We often will start with oral medications and then add others as needed. And that's a whole nother topic of different medications that we use to treat diabetes, but usually we kind of start small if it's well controlled, and then we'll go big as things get worse.
Jason, you're dying to talk about CGM, so we've got a lot of questions, so I want to get that in.
Thanks, Ray.
And then maybe talk a little bit about treatment.
So CGM stands for continuous glucose monitoring, and one of the biggest barriers, people would come into a clinic and I'd try to treat them, and I have 2 blood sugar readings over the last 4 to 6 weeks. I don't know. If I give them more insulin, I put them at risk of overdosing on insulin and getting sick. So now with continuous glucose monitoring, which I encourage everybody to talk to their healthcare source about whether they're eligible and whether they get it. It is a patch, you've probably seen it on TV, and there are numerous models out there, but it can read your blood sugar nearly continuously. So there's no more poking your finger, and it tells you, it can even tell 8 to 10 of your friends via their smart devices if your blood sugar is going up or down. So if you had an event where you were gardening and you passed out, your partner would know, hey, it would alarm and let them know. So this is revolutionary, not only for us being able to say, yep, your blood sugar is going down, at night, maybe we'll back off on this dose, but after dinner, you must have too much cake. We need to bump things up a little bit. It's just, knowledge is power in diabetes. Yep. And so it's better for the patient, it's better for us, and I think I'll leave it at that. Move on to the next question.
Well, if I may just, interestingly, now CGMs have even entered into the fitness market. Now you can buy a CGM without a prescription. Stello, which is made by Dexcom, which is the popular CGM company, offers it for sale for just anybody to use. It's got much more uses now that you say.
Is that through the skin, or is that with a needle?
It's through a small cannula under the skin, yes, but it has to go into the subcutaneous space.
Because there's a lot of questions, we don't have a lot of time. Let's talk about thyroid.
Yes.
Hypo and hyperthyroid, those questions are here. And this is kind of an area you're very interested in, so tell us about it a little bit. And then your props.
Yeah, so the reason why I got these props is because when you talk about thyroid disorders, this is not seen recently. It was in the past. There's something called endemic goiter. And endemic goiter was a condition which was in the past because there was no iodine supplementation in the diet. It was popularly seen in geographical regions which were mountainous and did not have areas where there was proper iodine in the diet. As we know it, iodine comes in the sea, and so shores and all the places that were next to a seashore had enough iodine. But geographically deficient areas did not have them. And surprisingly, there are 2 areas in the US which are geographically iodine deficient, and that's the Pacific Northwest and the Great Lakes area. And that's because when the glaciers retreated, they took away the topsoil. And so we are in an iodine deficient zone. And so it's very important for us to have iodine in the diet because iodine, the thyroid is like an iodine pump. All it does is takes iodine from the blood and pushes it onto proteins and sends them out. And so it's a very important component. And so it's very important for pregnant women to have a proper iodine in the diet. 150 micrograms is the RDA, the recommended dietary allowance for healthy person, and goes up to 250 even for a pregnant woman. And so from that point, what we have noticed now is there's been an increase in not introducing iodine into our diet. And that comes with many reasons. Processed foods, if you buy food from a restaurant or just buy processed foods, they're not going to put iodine in the diet because it's more expensive, it changes taste. So if a person is on a processed diet food, on a processed, buys a lot of processed foods, they're going to be iodine deficient. And then is the new fad of using designer salts. And so that's like, we have some examples here. Now this is kosher sea salt, and here is Mediterranean sea salt, and then Himalayan pink salt. And so this is touted as the best salt in the world without any polluted oceans. And there's no sea salt from any sort of polluted oceans. But what you need, as in all these three ones, they do not have iodine in them. And some of them especially make it, and they have the statement that says this salt does not supply iodide, a necessary nutrient, but they don't necessarily have to use them. Now this is $9.99, this is $12.99, and this is $13.99. But what you really need is the $3.99 iodized salt, and that will help your thyroid gland. So that was my props.
So one other thing on the treatment of thyroid or of hypothyroidism, desiccated thyroid versus generally we're using levothyroxine or whichever. Jason, do you want to take a shot at that one?
I think I would defer to Dr. Kasturi in that, levothyroxine
I was giving him a break.
is the gold standard, and I'm personally a little nervous when anybody is using any sort of, just because how do you want to make sure that it's of sufficient purity and of sufficient potency, and it's levothyroxine is the gold standard.
That is exactly right, because we don't know, because these brands that have, it's basically from a pig. So that's pig thyroid that's desiccated and brought in. Now the biggest thing about that is that's very important, that we don't know how good it is, how pure. There's no large scale studies to show that that is as good and effective. And the biggest problem is that has both T3 and T4. Now there's a difference between the two. T4 is not metabolically active. It gets converted to T3, and T3 is the actual one that actually does the job. And so the body, the actual thyroid gland secretes a very little amount of T3. What it does is T4, it sends it to the cells, and the cells use T4 to make it into T3 as an as-need basis. So it converts it when it's required and then sends it to the cell. But when you have this pork thyroid that has T3 in it, now you are infusing the body with all T3, which you may or may not need. And we should understand that the thyroid is not just a metabolic hormone. It works on the cardiovascular, it works on mood, it works on growth, it works on digestion. So now we are activating all these systems for no reason at all. So as you correctly said, we always advise them to use regular T4 synthroid levothyroxine rather than this brand.
Chris, any comment on that one?
I would have to agree. The gold standard is levothyroxine. You do see patients who prefer. It's usually branded Armour thyroid. It's hard to convince them otherwise, and you always have to meet your patient where they're at. But I think the most important piece of knowledge that I would add there for the public is it's really important just to continue to monitor your thyroid. And whether you choose to take levothyroxine, which is probably what your physician is going to recommend, or Armour thyroid, the most important advice I would have is that you need blood work. You need to make sure that that medication is being dosed appropriately and your body is not being over or underdosed, because many tissues are affected by thyroid hormone. So that
Thank
would
you.
be.
Jason, why is the prevalence of hypothyroidism and diabetes so high? This is from a nurse. And anybody else can jump in, because I'm not sure I know the answer.
I cannot think of any immediate connection other than if you had some sort of an autoimmune process, that there are multiple sort of endocrine immunologic conditions that could but yeah, I can't think of a direct disease that captures both of those that's common. I think certainly diabetes is incredibly, and I did want to follow up. There was the earlier question of type 1 diabetes and type 2, and I think we didn't really get to the type 2, and type 2 is much more of, so type 1 being,
Go ahead.
Your pancreas doesn't create it. You need insulin to survive, to stay alive. Type 2, your pancreas is still making insulin, perhaps not enough, and the tissues in your body aren't able to properly utilize you have an insulin sensitivity, so you need more and more insulin, and so that's the vast majority of diabetics are the type 2 diabetics, that they're still producing some insulin, but we have to use a combination of more exogenous insulin that we inject, and then other medications that make our body more sensitive to insulin. And but yeah, I think I'll defer to my colleagues here, because I can't think of apart from a couple rare autoimmune conditions, I can't think of a combination a disease that's going to give you hypothyroidism and diabetes at the same time. I think both of them are just very common conditions, and so the fact that they'd be coincident is certainly possible. But
I don't personally think that the percentage of either has increased over time. It's been kind of constant on the amount that there is over a lifetime, but I'm not sure. That was, is diabetes related to lymphatics? Anybody got a shot on that one?
Lymphatics is the immune system broadly, so I guess it's related in a way, but not directly. No.
No, it's a separate, I would say, yeah, it's more of an endocrine, so an organ that produces a hormone system.
certainly related to your metabolism, especially. I think one of the most common things I see are people, their triglycerides are out of control, their cholesterol is out of control, and when you don't have insulin and your liver doesn't quite process the fats that you consume, and your triglycerides can be through the roof, you can get pancreatitis from these excess triglycerides. And so once you control your diabetes, with insulin or other medications, your lipids, meaning your cholesterol profile, triglycerides, get much better. And so that's an important thing to always keep an eye on.
Can you self-manage your diabetes with diet only?
Certainly.
Go ahead, you can.
Yeah. Especially,
Type
not type 2. Sorry. Type 1, absolutely not. That's lethal. I think we established that. But anyways, type 2, especially if you're pre-diabetes or in early stages, with the help of eating correctly, healthy, regular exercise, and certainly weight loss, you can control your diabetes without medications.
Yep.
When do you need immediate intervention for hyperglycemia? Like what level? I'll leave it
What's
to you
that one?
guys.
I don't think there's a set number. It differs because for people who have diabetes, they might run into sugars like 250 and they'll be fine. They can adjust to it. It all depends upon how much your body can cope, at what level it starts producing acids and starts breaking down fat in response to not using thyroid. So there's no one number. The 126 is the official fasting blood sugar number to diagnose diabetes. Anything greater than that, but otherwise there's no number to act on. It differs on each patient and case.
Yeah, you can. When your blood sugar is, 600, 700, you can start to get severely dehydrated, and if it gets, much above that, you can have some, what we would call you have some changes in the consistency of your blood that can lead to confusion, and along with the metabolic, and acidosis that can be fatal.
Blister on your shin, is it a concern if you're diabetic?
Blister on your shin, absolutely. Any skin is probably our most important defense against infection. And when diabetics, they are prone to a peripheral neuropathy where they lose feeling in their feet, and they often stub their toes, damage their skin, and that's a doorway for infection. So good foot care for diabetics is imperative.
This person takes long-acting insulin and fast-acting insulin. What does this do to his pancreas or her pancreas? And to his pancreas's natural ability to produce insulin, and will it produce less? There's a lot in there. We got a minute or so.
Okay.
Krista, do you want to grab
Sure,
that?
I'll take that. Okay, so if a doctor is prescribing insulin, it is presumed that the pancreas is not making your own insulin. And so probably it does nothing to your pancreas in essence. It's taking the place of your pancreas. I always tell my patients that when we dose insulin, we try to mimic how the pancreas does it for us naturally. For example, the reason for the long-acting insulin is because The pancreas naturally secretes what we call a basal rate of insulin, so a continuous amount. And then our pancreas is smart because of a bunch of mediators that are given off in our stomach and our liver and our even, our brains help. There's many different mechanisms that tell our pancreas that we've eaten, for example, and we need more insulin. And so that's what we call a prandial amount of insulin. We usually use the short-acting to supplement for that. So long-acting is the basal, and the short-acting is usually the prandial, which is given when someone eats.
Could a burning sensation be a symptom of diabetes?
When you pee? Or just in general?
Yeah.
Heartburn?
Any one of those.
Diabetic peripheral neuropathy that's, you see the pictures in the magazines, people with blow torches under their toes, especially at night, burning in your lower extremities, in your hands, is all very, very consistent with the diabetic neuropathy.
Thank you, panel. We didn't get to a lot of things we should have. I want to thank our panelists tonight, Dr. Kannan Kasturi, Dr. Krissa Koide, and Dr. Jason Wall, and our medical student volunteers, Jessica Crossan, Mackenzie Peterson, and Wyatt Windhorst. Next week, please join Dr. Mary Owen for a program entitled Indigenous Health, when our panelists will be Dr. Ryan Dunkley, Dr. Charity Reynolds, and Ricky Defoe. Thank you for watching. Good night.